Good afternoon, everyone. My name is David. I am a neurologist from Sheffield, and it's my pleasure today to introduce and chair today's webinar. So today we're going to be looking at whether patients on low-efficacy disease-modifying therapies should be allowed to switch to a high-efficacy disease-modifying therapy without having to wait for a relapse or progression. My name is David, but I'm joined today by Shamali, Antonio, Joella, and Noreen, and they're going to help us work this out. Thanks very much to Roche, who have sponsored this. They've had no control over the educational content of this activity, and this goes with their support of the MS Academy. What we'll do is we will launch a quick poll at this point to see what you in the audience feel. So please you should get this little box coming up in your screen that indicates your thoughts about whether patients on low-efficacy disease-modifying therapy should be allowed to switch without having to wait for a relapse or progression. We'll run the poll later to see if either of our speakers and our debate has changed your mind. Yeah. So about 85% agree with Shamali that patients should be allowed to switch, and 83% with Shamali, 17% with Antonio. So why are we doing this? Well, I think as an MS community, we've got quite comfortable with the idea that high-efficacy treatments are associated with better outcomes for people with multiple sclerosis, and we're pretty comfortable in discussing these at patients when they start on their treatment and where patients have had breakthrough disease. But I think where it does get a bit difficult in clinical practice is those patients that we're thinking about today, those patients who come for their routine review, they seem to be doing fine, but you're aware that there might be something better out there. How is it that you discuss with things? Are we true or are we overreaching? And what sort of difficulties will this make to our services and the variants that we see around the country? To help us, we've got a couple of very bright minds who've thought a lot about multiple sclerosis. First up, Shamali is going to take us through her presentation. So Shamali is presenting Shamali is a consultant neurologist at Barts in the London Hospital, but also she's uniquely well suited to helping us with this question because she's thought a lot about some of the more subtle damage that can be done in multiple sclerosis via her work on biomarkers, particularly neurofilament. Shamali, I think, will provide us with really interesting thoughts about exactly what is going on with multiple sclerosis patients and what's happening at the time that we see them in that clinic, even when things are stable. So Shamali, you're very welcome. Thank you very much.
Thank you, David, for the lovely introduction. I think I'm preaching to the converted here, so I may actually lose on the swing ward. But anyway, let me share my presentation and get started. I hope everyone can see this. So I'm going to be arguing for patients on low-efficacy DMTs being allowed to switch to high-efficacy DMT without having to wait for relapse or progression, i.e. demonstration of disease activity. Before I proceed, wait a minute. Let me share this and redo this. These are my disclosures. None of these are in conflict with the presentation today, but they have over the years colored my viewpoints, which I'll be presenting for this talk. So I'm arguing for patients being allowed to switch or escalate to high-efficacy DMT from low-efficacy DMT without having to demonstrate disease activity. I'm going to present 4 clear arguments for this, some of which many of you would already be aware of, i.e. known truths in our current MS knowledge, as well as unknown truths, which not many of you may be aware of. So the first and foremost, which is the prima facie argument for this, is that early treatment with high efficacy DMT has the best outcome. As the stroke physicians have coined initially, time is brain, and this very much applies to MS, which is a very disabling chronic condition. And we know that MS activity in the first few years determines disease trajectory, which I'll present in the next couple of slides. And high efficacy DMT treatments at this early period has the best long-term outcomes. So this is a graph which my co-host Antonio would be very familiar with, which is looking at the predictive value of early disease activity on survival. This is the London, Ontario cohort and findings, which shows that relapses in year 1 and 2, when you look from time from disease onset to disability score of 10, which in MS terms means death, that if you have high number of relapses, you're more likely to reach this time point at much lesser in terms of years. And if you look at those with some form of disability already, which is a score of 3 to time point of 10, i.e. death, you still see some form of a reduction in mean time to reach these if you have more activity, but it's less apparent, suggesting that as far as MS is concerned, we have a very narrow time window in which to act on, which is very early on in the disease. Now, if we look at conversion to SPMS and the DMTs used, this retrospective study from MS Base, which uses under 2,000 patients, showed that, in fact, starting on platform treatments such as glatiramer acetate or interferon beta versus fingolimod and alemtuzumab or natalizumab, definitely they have a greater proportion reaching progressive MS. So what do we know from these two data is that we're out of date in our current practice of MS. This goes without saying. Our evidence, or there's mounting evidence suggesting that we should be treating early and with higher efficacy DMTs, but our current practice in majority of instances is heavily reliant on escalating from first line treatments to second line treatments, therefore losing time in the course of this disease. So we really need to change practice, and if MS patients can escalate, they should be allowed to escalate. So secondly, and more importantly, the longer one is practicing MS, we realize that there's no such thing as benign MS. Majority of patients do progress. And what we have done in the past, and probably still doing for a certain extent, is classifying MS in clinical terms, but we don't have clear biological basis or foundation to decide or back up this argument. Two of the things which I've often pondered over is concurrent infections in MS. We class this as pseudo-relapse, but is this really the case? So if we look at UTIs, for example, patients come in, but when they're discharged, they are discharged with greater EDSS scores than when they came in. So are we considering these as pseudo-relapses, or are they actually true relapses? And then many of our patients also experience a lot of background symptoms, tingling being one of the most common symptom presentations. And we take this as the norm in our patients and not an indicator of disease activity. But is this really the case? As we know now, there's such a thing as smoldering MS, and possibly this is minutiae smoldering disease activity, which is happening in the background. So based on the fact that we do need to treat early and that we don't really understand what is smoldering MS, and there is no such thing as benign MS, really we should be focusing on the evidence and treating early and allowing people to escalate. And this graph is interesting in that it's pre the massive DMT era. So this was published by Hawkins back in 1999, which looked at the progression of patients who were classified initially as benign MS. They took, as you know, the interferons came in the mid-1990s. They looked at data from 1986 and 7, and 10 years down the line in 1996. And what you can see is an increase in EDSS score in many of the patients classified as benign MS. So an interesting point which the authors pointed out is that the label of benign MS is often temporary, and apparently benign disease often becomes disabling. So really, I hope this takes home the message that we should be treating early and allowing patients the choice of being on highly active DMTs early on. Now, the second issue, obviously, is not probably known to everybody, but our current categorization of disease of MS as a disease is based on licensing initiated by pharma companies as early as 1990s. If we look at the initial interferon beta trials, they were paramount in making relapses the fundamental criteria in deciding how we managed MS. And since then, we've been wrapped in a loop of only considering relapse activity as the marker for MS disease. So the initial trials demonstrated that over 1 to 2 year period, interferons reduced relapses on average by 30%. Following on from that, other treatments such as natalizumab, which have come in, have shown greater efficacy in relapse rate reduction and have been classed as second-line drugs. This doesn't take into account remyelination or smoldering disease activity, although we are now starting to look at progression. And this brings me to something which I think of as a treatment clinical paradox, which some of our patients unfortunately land in very quickly, which is that they may not demonstrate disease activity and therefore will be ineligible for escalation. However, after experiencing disability progression following a relapse, they will have missed the opportunity to escalate. So by creating all of these artificial guidelines, what we have left is a great unmet need for patients who really do deserve to be treated. And then last but not least, compliance often does determine treatment success. We need patients to actively participate in their choice of treatment. At best, non-compliance rates are 20% across the board in treatments, not just in neurology. And so we need to encourage active participation. And the way you establish that is to establish trust with your patients that their matter is being considered and their clinician is actioning appropriately. And as you can see from this, the difference in admissions in adherent patient groups versus non-adherent, often these patients are the ones experiencing severe MS relapses, more inpatient visits and ED visits. So in summary, the basis for supporting patients on low efficacy DMTs being allowed to escalate to high efficacy DMTs is based around my understanding of 4 fundamental points, which is that first and foremost, our treatment strategies are out of date. Time is brain, and we should be treating early with high efficacy DMTs. And there's no such thing as benign MS. We do really need to move away from this case for argument, as the data demonstrates that given time, all of our patients do progress. It's a matter of how long we follow them up. And last but not least, we are in this loop of thinking about management of MS as relapse rate reduction, but this needs to be reevaluated, and all forms of other disease activity needs to be included. And therefore, those who may not have been able to escalate can now escalate if we change these criteria. And we need to avoid this clinical treatment paradox, which I mentioned before. And last but not least, compliance definitely determines treatment success. So if we are demonstrated to act according to what we already know, then we are more likely to encourage compliance in our treatment decisions. Thank you very much.
So good morning. My name is Dr. Antonio Scalfari. I'm one of the consultant neurologists at Imperial College. And just a second, I'm going to argue against the notion that patients on low efficacy DMT should be allowed to switch to high efficacy DMT without having to wait for a relapse or a progression. And these are my disclosure, which has no implication in the current talk. And let's start with the difficult process of treatment choice. We have a large number of disease-modifying treatment available for MS patients, and it is generally accepted that those compound with higher efficacy comes at the cost of potential more severe side effect. So choosing the right treatment is a shared decision process with the patient. And in principle, this process is driven by the assumption that what we offer should be should have much more benefit than risk. So the benefit related to the therapy we offer should outweigh the potential risk. And this complex process takes into account several different information and criteria here listed. But I fully agree with Sharmli that it is becoming more and more popular, the concept of hit hard and early. And I'm a strong supporter of this view. When I can in clinic, I tend to use monoclonal antibodies early in the disease course. Data have consistently showed that the early use of highly active treatment is associated with a much better prognosis. And an induction, so-called induction therapy compared to an escalation therapeutic approach is associated with a reduced risk of disability accumulation. And so therefore, this is, as Sharmli has also shown, is supported by a good biological rationale, given that the important prognostic relevance of early focal inflammatory activity. Therefore, it makes sense suppressing early focal inflammatory activity quite aggressively if we can. However, the question that is posed here is a bit different, because we are looking at discussing whether patients who are actually responding to low efficacy drugs should be allowed to switch to high efficacy drugs in the absence of any form of disease activity. And to address correctly this question, I think we should start from remembering how disease-modifying treatment were approved in multiple sclerosis. And this is because in clinical trials, they primarily were shown to be able to suppress relapses and to prevent the formation of new lesions on the MRI. And secondarily, they were able to prevent any form of disability progression as assessed on the EDSS. And based on trials results, we created the so-called concept of NEDA, so no evidence of disease activity, which represent our most important therapeutic target. We treat to achieve a NEDA status. We treat to achieve to suppress, to stabilize the inflammatory parameters by suppressing relapses, by preventing new MRI activity, and to avoid eventually the accumulation of any further disability. So that's the main treatment goal to bear in mind. So why, even when we achieve such a treatment goal, even with low efficacy treatment, should we consider any other form of therapy escalation if we are already achieving the desired treatment outcome? And it's important to bear in mind that NEDA3 is not a sustainable outcome over time. And this has been nicely demonstrated by several studies. Here I'm showing a study of about 200 patients. Half of them were receiving platform therapy, first-line therapy. Half of them were not receiving any treatment. They were followed up for a median time of 7 years. And as you can see, the proportion of patients to remain with no ongoing disease activity gradually declines substantially over time. Impressively, after only 1 year from the commencement of therapy, almost half of patients have already lost their NEDA status. And this dropped more after 2 years. And eventually at year 7, merely 88% of patients were still not experiencing any form of disease activity. But if we look at these data from a different angles, I think it's important to highlight how prognostically good is to maintain a NEDA status. So among those patients who were free of disease activity, it was shown that being free of any form of disease activity, either inflammatory or disease progression on the EDSS score, reduced dramatically the risk of developing further disability 7 years down the line. So it was worked out in this study that being NIDA at year 1 associated with a more than 70% risk reduction of experiencing EDSS progression 7 years later. And this obviously increased when being NIDA at year 2, and even more consistently when being NIDA at year 4. That implies that being remaining free of any form of disease activity thanks to any treatment, it bears a very good prognostic, it represents a very good prognostic indicator. So when considering whether escalating to a stronger compound in the context of no ongoing disease activity, we should keep this under strong consideration and consider very carefully whether it's worth escalating to a stronger compound. And to further address this point, I would like to discuss further what implies responding to a therapy. Some studies have shown that when a patient responds to a single treatment, the response is probably much larger than what was shown in the randomized controlled trials, which applies to the average population treated in the trial. And that was nicely shown by one of the studies led by Maria Pia Sormani's group, which they look at a specific statistical modeling, which allow to distinguish based on certain clinical, demographic, and radiological features, responder or no responders within the same cohort analyzed. And they apply this methodology to some 2 main trials of laquinimod. For those who don't remember, laquinimod was a drug that failed to meet its primary endpoint, suppression of relapses, but it managed to achieve a significant, albeit modest, prevention of disability accumulation by approximately 30% in the 2 main trials. And for this reason was never approved for the use of relapsing-remitting MS. So Maria Pia Sormani group applied this modeling to the 2 main trials of laquinimod, managed to identify a population of responder. And as you can see, compared to what it was shown in the original trials, when they look specifically at the responder, the size of the treatment effect was much larger, actually double with what was originally shown in the trials when it is actually applied to the average patient. And that, in other words, is telling us that when a patient responds to a specific treatment, even if the specific treatments such as platform therapy are perceived to be like low efficacy drugs, but in the single individual patient, the treatment response might be much larger than what it is actually seen in randomized controlled trials. In addition, we have to also take into consideration that loss of NIDA does not automatically imply poor prognosis. And this was very nicely demonstrated in this large cohort study of more than 1,000 patients who received interferon or glatiramer acetate and follow up for 10 years. As you can see, those with a low level of disease activity, despite being on treatment after 1 year, so those who didn't experience any relapses, but had up to 2 new lesions on the MRI, had a relatively low risk of reaching EDSS-6 down the line 10 years later. And obviously the risk of reaching EDSS-6 increased substantially if patients experience more than 2 new lesions on the MRI, or even more if they experience also relapses on top of that. But even a low, based on the statistical model that had developed in this study, they managed to define the concept of minimal evidence of disease activity, whereby patient wouldn't experience any relapse, but no more than 2 lesions on the MRI despite being on treatment. And they nicely demonstrated that those with minimal evidence of disease activity have very similar outcome to those with no evidence of disease activity. So the similar proportion of patients in the 2 groups reached EDSS-6 and had very little changes overall in the EDSS score. So the bottom line here is that even when patients are not fully responding to treatment, a minimal level of disease activity doesn't necessarily imply that we should consider therapy escalation, because it's not necessarily related to an increased risk of developing severe disability much later in the disease course. And I would also like to remind that despite what Sharmili said in her presentation, somehow a benign disease course can still happen among patients. And I'm not going to show you any data on benign MS, but I'm rather showing you the natural course of patient with presenting initially with very early adverse clinical features that are meant to experience a severe disease course. This is the analysis of the London, Ontario database of patients with at least 3 relapses during the first 2 years, who were followed up for 28 years. And as expected, as it was shown in Sharmili's presentation, those patients, the majority of patients with at least 3 attacks during the first 2 years had an aggressive disease course. They attained secondary progressive in relatively short time, within, I think the median time was 9 years. However, 1/3 of these patients, which is not few patients, just 35% of that group, despite having early adverse clinical features, they didn't reach secondary progressive MS after 17 mean years of disease duration, and they were still free of severe disability. So I would argue against what Sharmili said, that benign MS doesn't exist. I would prefer say that a mild disease course, MS can present with a mild disease course down the line, even when patients are not receiving any disease-modifying treatment, as it was shown in the analysis of the London, Ontario database. There is also a biological rationale for avoiding using highly active treatment in the late stage of the disease, later in the disease course, because we know that the focal inflammatory activity, which is the main target of disease-modifying treatment, tend to decline with disease duration and age. The annualized relapse rate becomes lower with the disease duration, the so-called regression to the mean. And by growing older, patients tend to experience less relapses. In contrast, the risk of developing severe secondary progressive MS increases proportionally by disease duration and by growing older, arguably led by an increase of degenerative phenomena, which are not targetable as things stand right now by currently available disease-modifying treatment. And indeed, it has been nicely demonstrated in several randomized controlled trial sub-analysis that the response to disease-modifying treatment is strongly age-dependent. And we know that higher efficacy of DMT is predominantly seen among younger patients. So if a patient remains stable on a platform therapy, and by the time the disease goes on and patient grows older, we should consider very carefully whether it's worth escalating to a stronger compound. In addition, age can affect also the probability of experiencing severe side effects from treatment, especially when considering depleting agents such as cladribine, ocrelizumab, or alemtuzumab. This is a meta-analysis recently published last year showing how age did not affect the incidence of infection, but among those patients receiving depleting agent, age explained almost 30% of the variance of neoplasm rate of the occurrence of cancer. And the risk of cancer associated with depleting DMT became significantly higher after the age of 45. Of course, we need to take into consideration long-term safety of highly active treatment. We're all familiar with the story of natalizumab, where the risk of PML gradually emerged in trials was not initially expected, and the risk of PML gradually increased with the number of infusions. But most striking is the story of alemtuzumab, which was used for years as a first-line treatment. I did prescribe alemtuzumab to many of my patients as a first-line treatment. And eventually there was a new restriction applied based on serious cardiovascular reaction, which emerged later in the years, therefore restricting the use of alemtuzumab. We have received reassuring signal from the long-term safety of ocrelizumab, which is currently the most commonly used highly active treatment. Doesn't seem to be any increased incidence of malignancy among ocrelizumab treated patients, and the rate of serious infection fluctuate over time, as reported in the last 7 years follow-up study, but show no meaningful year-to-year variation. So there doesn't seem to be a cumulative risk over time, but who knows what will happen with the longest observation. And finally, last but not least, the importance of the cost of DMT. If we change our escalation criteria, more patients will end up being prescribed highly active treatment with significant both financial and logistic challenge for our services. So just to summarize my point, let's always never forget that the treatment choice is based on the assumption that we would offer the drug with whose potential benefit would outweigh potential risk of side effect, and the treatment responders with no evidence of disease activity have a significantly reduced risk of disease progression in the long term. So there is no biological rationale for considering switching to a different compound when neither is achieved. MS can present with a mild course, and we know that it becomes less inflammatory over time, therefore less targetable with currently available disease-modifying treatment. By growing older, treatment response decreases, and the risk of significant side effect proportional increase, and this has to be taken into consideration if we are considering switching patient to a highly active treatment later on when they are growing older, especially if there is no biological rationale driving our therapeutic choice. And finally, an increasing number of patients on highly active treatment can pose significant financial and logistic challenge on our system, on the MS service, and should be taken into consideration. Thank you for your attention.
Oh, thanks so much, Antonio. And my severe apologies for not being able to sort out the difference between the two sides there. I think it's all sorted out now. I think the technology is sorted. But an incredible presentation, and you may not have been preaching to the converted, but I think as a heretic, you were very compelling. Ladies and gentlemen at home, I can't imagine that you've never come across this situation. So we'd be really interested in any questions that you have for us and the panel, or any observations. And there's a Q&A function, which is just at the bottom of Zoom, which you can use to let us know what you think or what questions that you'd have. I'll open things up to my panel in a minute, but Shamli, may I ask if you've got any quick reactions to what Antonio has told us, his compelling account of what happens to people?
Sorry, Antonio, I don't want to burn you at the stake, but I think you presented a very selective argument there for our audience. I could think of so many counter or what if, not to mention that. And my main argument is to move away from these clinical classifications. The current one, which is infamous, is NEPAD, for example, which is progression or disease activity. There are better outcomes, which David Pelling's already mentioned, which is neurofilaments. And I might add that if we look at the progressive treatments now, that if you use neurofilament light chain, which is a marker of active inflammation, and we take drugs such as subcladribine, for example, which Klaus Schmierer is now doing a phase 3 national trial on, looking at efficacy in progressive MS, even at later stages, you can achieve quenching of the disease. So MS by foundation is a disease of the immune system. It's always going to be there. It's just a matter of selectively targeting these patients. And also we have good risk stratification processes in which we can look at and remove the risks of natalizumab and PML risk. We don't really need to worry about that per se. We can say if they're JCV positive or negative, and even limit it to 2-year application. And alemtuzumab, which you're a great user of also, is something which, if you select your patients well and not give it in 70-year-olds, which led to the unfortunate use of it being pushed to third line, which is what Americans were doing. They were using it in third line in older age groups, which led to the problems which which have arisen. So I go back to the argument that the better outcomes come with early treatment, and we don't need to rehash the older theories in these arguments. Thank you. That's I know I'm now starting to rant, but I will stop there.
The sermon has been delivered, Antonio. Any quick questions about that before or thoughts about that before I open things up to the floor?
I think Sharmila is having very valid argument. I accept that. I mean, and it's true that most of my presentation was around the concept of NIDA, and NIDA has got its limitation. There are other forms of disease activity that goes beyond relapses, new inflammatory MRI lesions, and EDSS progression. The emerging concept of PIRA now is becoming the trendy, the new kids on the block, or even neurofilaments, as you pointed out, are a form of disease activity. The point is, I'm not convinced about evidence supporting a therapeutic effect of currently available treatment on those outcome measures. Those outcome measures indicates that there is an ongoing disease activity that goes beyond focal inflammatory activity. I'm not entirely sure whether currently available disease-modifying treatment are correctly suppressing that type of disease activity. Therefore, I think we're still in between. I mean, currently, what we know from trials, and that's what I base my presentation, is that currently available disease-modifying treatment are able to suppress relapse, to prevent new MRI activity, to prevent the progression on the EDSS scales. And based on that, we need to stick to that, to the concept of the NIDA. Whether NIDA will change in the future, I think it will. We will go through NIDA 4, NIDA 5. I wasn't even sure whether including in my presentation brain volume loss as a NIDA 4 measure. But again, that was a bit tricky because we don't know whether many of those treatments actually impact on the brain volume loss. We have few available data. So as things stand right now, I think we should stick with what we know for sure. But I do agree, it remains a big, huge gray area, which represents one of the biggest unmet needs on how to further address ongoing disease activity beyond the element of NIDA 3.
Very compelling comeback, Antonio. I'm swinging side to side. Joella, we've forgotten one thing about this is that, no matter how compelling our speakers are, we're just not allowed to do this at the moment, are we? Is that true? And do you think that could change?
I think, currently, we should be using the Blue Tech criteria, the commissioning criteria, so whichever area in the country you're in. But the commissioning criteria is based on evidence. So if people are doing this and there's real world evidence, and that might not be from the UK, it could be from other countries, it's then asking NHS England through the ABN, through the CRG, to actually review this and say, actually, there's evidence to do this and it's not harmful. Or let's conduct a trial. Let's, as a community, do a trial and do it properly. But currently, no, although as much as obviously the community, the original poll had said, we support the use of high efficacy, we do need to follow the commissioning criteria. And Antonio mentioned the cost. MS drugs aren't cheap. We do need to be careful how we use the taxpayers' money, and which is all of our money, for the population, which is hard when you've got an individual patient in front of you, because you want to do the best for them. And that's where it's a difficulty and the difference between patient level care and then population level care.
Adding even more levels of complexity, Joella. Noreen, these patients come to you and they must ask you about this. What's your thoughts about how to deal with this question, and how, in your experience, do patients take your answers?
I think quite often people will come in and have questions about the higher efficacy treatments, that maybe these are treatments that weren't available when they were newly diagnosed and first went onto DMT. And I think it's probably why in reality in clinic we are looking for any subtle changes or any reason why we could escalate somebody. I suppose, if somebody is on a lower efficacy treatment and they're doing well on it, you've got the argument of, if it's not broken, there's no need to fix it. But I think it's for those patients that maybe you've got the concern that maybe they're not doing so well on their lower efficacy DMT. But I totally agree with Joella. The pot is not ever never ending of money, and And certainly the last 12 months, we've had our high cost drugs on the top of the budget line, which is always a little bit scary to look at. But I think it's I think it's trying to balance out that picture, and I suppose really it'll be really interesting to see what NHS England do and whether or not that fantastic algorithm will change or not. But I agree with Joella. I think it is going to be down to us as a community proving the worth.
Can I just come back on the cost here? If we look at QALY, the high efficacy drugs trump as far as quality measures are, and surely that should be the argument we're using. If we, beyond EDSS score of 6, quality of life for MS patients drops to nihilism, as majority of the studies have shown. So we shouldn't be looking at EDSS scores higher than 6. I mean, really, we should be aiming for EDSS scores less than that. And when you look at the 25 years worth of contribution lost to employment, social issues which arise very early, cognition knocks out most people from social interactions very early on. The actual cost benefit for the higher efficacy drugs outweigh that of low efficacy by miles, in my opinion. So I think the problem here is trying to make nice regulatory boards, which unfortunately doesn't have MS physicians sitting on it, understand the quality figures, because these figures are presented by epidemiologists when drugs go for licensing, who are not able to present the patient advocacy as well as a clinician or an MS advocate can present it. So there's a thing here which needs to be fixed, but it needs to happen at a much higher level, really.
Great points, great points. Speaking of the community, we've got some questions and points from the Q&A, and there's still time, so you're very welcome to put in some other things if you have a strong question or a point that you want to make. So someone just makes the point, a statement rather question, one of the advantages of working in the NHS is not having to consider what the cost of the medication is when the patient is sitting in front of you, which is a nice thing to remember, isn't it? When we spend a lot of time telling ourselves how terrible it is working with the NHS. But yeah, it's a really good point, isn't it? That as long as we behave the rules, we don't have to have our patient's ability to pay in the back of our minds, which
and David and NICE have done that thinking for us, and NICE have and back to Shamli's point that the high efficacy drugs are very cost effective. The problem is your trust or your bank balance right now is paying for that drug now, and that's where the difficulty is. So it's getting not only NICE but everyone to realize the benefit is to social, the economic, the politics in the future. It's like the argument is we want to pay now to save in the future. It's very difficult when you've got limited resource now.
No, and it pays someone else, doesn't it? It pays for social care rather than, it doesn't help the hospital out. That's what they always say.
In England, as we move to ICSs and ICBs, it should be one, and hopefully that's the right direction of travel for the NHS, that the benefit seen in social care, etc., will benefit healthcare. But it's difficult because the benefit isn't today, but the cost is today.
Absolutely. So Dominic has asked a question. Dominic Shadbolt, he says, RE disease course being mild, what percentage of patients make it through MS never passing EDSS 3? I don't know if Antonio, if that figures
I think
to hand, but
that's a very relevant question. I think very small percentage. I can't quantify, and it's not on top of my mind. But it should be approximately around 10%. It's, I mean, progression, secondary progressive MS is almost an obvious outcome for most of patients. Sooner or later, they will enter a sort of form of secondary progressive. But a proportion, although small, it still remains free of progression, or at least it doesn't go beyond a moderate level of disability marked by the attainment of EDSS-3. But I think in the context of the discussion we're having, I think it's important to bear in mind, as it was pointed out by Shamli, that the highest cost-effective of the highly active treatment is early in the disease course. And I do strongly agree with that, because biologically we know that the inflammatory component of the disease is very florid during the early stage. And then it becomes, it tends to decline and is taken over by more degenerative process, which, and the big debate remains whether those processes are actually influenced by focal inflammatory activity or not. So my main struggle is not prescribing highly active treatment. I'm not bothered by cost. And if I face a newly diagnosed patient with a lot of inflammation, I go for it straight away, which probably I tend to prescribe much more than in many other centers. But my main problem is when I face a patient 15 years down the line, who is actually on low efficacy drugs, is doing well, there's no actual sign of disease activity. Patient is growing older. We know with growing older, inflammatory component tend to decline and so on, along with the disease duration. In that case, the balance between efficacy, risk and benefit and side effect, I'm not sure whether it's strongly in favor of potential benefit compared to the risk. There's a lot of, the balance tends to change by the time the disease goes on and patient grows older. So that's where the difficult question is. It's not difficult to give early in the disease course highly active treatment. That's pretty obvious, and I strongly agree with that.
That's tricky, isn't it? Just trying to work out exactly how your patient is going to benefit. Some people have put their hands up. I've never done this before, but I'm going to try and allow, it's a bit like a radio phone in, isn't it? So I'm going to try and allow Liz Watson. Liz, do you want to talk and tell us your question or observation? Maybe she pressed it by accident. We've also got Alaya SI. So Alaya, I'm going to allow you to talk as well. All right. While we do that, I've got one. So Liz or Alaya, whenever you work out the technology, I know it's not always easy. You're very welcome to talk. Monica Marters actually asked us a question, and Antonia, this fits to a graph that you showed. She asked, is the benefit of DMT similar in older patients? And actually, should we be using higher efficacy in younger patients?
Well, that's exactly the point we just made. The inflammatory component of the disease seems to be much more florid early in the disease course and among younger patients. And so it makes sense using highly active treatment when it's possible early in the disease course. And this is perfectly in line with all the randomized controlled trial sub-analysis, all agreeing in showing that the largest treatment effect is observed among younger patients, which is explained by the biology of the disease, which changes over time, becomes less inflammatory, in my view.
I think, can I add to that? Because there's more subtleties here than just simply age. If you put a treatment naive person at an older age category, their response rate can be quite phenomenal. And so there's something about switching through various disease modifying treatments which seem to make the immune system a lot more unmalleable. And therefore your failure rate increases as you go up the ladder, really. But if you take a treatment naive, and we're seeing this in our primary progressive patients who are older at when we start treating them, you find actually they have a better response than a similar comparator relapsing remitting person who's gone through several switches. So this is a very complex thing. I don't think anyone's looked at head-to-head comparisons, but maybe something like MS-based can look at that because they have large enough data sets to look at that.
And sharply with MS-base, I mean, it can sort of answer questions for us, but would it give us enough information to answer that question on a patient-by-patient basis, or do we need another test or another series of tests?
So I think what you're alluding to is, can neurofilament answer that question? It has answered it in siponimod study, and it has answered it in actually particularly in Klaus Schmierer's data, that the actual reductions, his age average range was about 50 median age, and they had phenomenal reductions. Some of them had 10,000 picograms per mil, which I would consider in the category for ALS in primary progressive MS. After treatment with just 2 courses, you got down to 4,000. I mean, the patient's still active in their disease, even at the age of 60. But if you do start putting these patients together, you see that the drops in neurofilament levels are equivalent to what you see in relapsing remitting MS patients. So maybe, the MS base will provide the multiple, like, for example, they'll have the MRI data, EDSS, but this study probably, if you pull out all the neurofilament data which has been published to date and start pulling out the patient characteristics, I mean, so Peter Calabresi's analysis on 3,500 patients, and you align it with Jens's, which is 4,500 patients, I think this can be answered, really. I think the two we're again defining by age and like clinical characteristics, but the disease is a lot more complex. And we know this from cancer, hem-oncology treatments. Once you start immunomodulating, you have a different beast to deal with. And so these kind of cancel each out as the condition goes on.
I couldn't put it better myself, but I suppose my answer, Shamali, is, or my question to you is that even if you have that patient with a neurofilament of 10,000 and you're able to reduce that down with your treatment, have you done them a favor, or have you missed the boat? What's your feeling about that? And is there any data to support you?
Well, I don't need to even say that. I mean, it's all published by Professor Schmierer. I mean, it's all shows that that's what critical in getting the phase 3 chariot study set up. So I think it does show you that if there is inflammation, despite what age, and his trial has no age cutoff, by the way. So you need to be able to pick out these people. It's like seeing the tree from the whole of the woods. You need to be able to pick it out. If we start cutting off at age, then we are again becoming very blinkered in our thinking of management of this disease. Definitely oncologists seem to only pack it in when someone's 90 years old. But if you look at multiple myeloma, we're treating 94-year-olds. I don't think they think of the immune system as something mild. They take it as a cancer, which is what they imagine.
But, sorry, I don't want to be mistaken in my statements. I never say that after a certain age we should never use highly active treatment. That's not what I said. It's simply that in the context of the risk-benefit balance, we should make more careful consideration, considering also that age might increase the incidence of severe side effect, a serious side effect in the context of especially depleting agent. So my point was just to be more careful in considering highly active treatment above a certain age, both because of the possible reduced efficacy that is observed at that age, but also because of the higher potential incidence of severe side effects. So when we do the careful balance between risk and benefit, age has an important impact in our assessment, I think. I'm not certainly say that after a certain age, those drugs shouldn't be used at all. If it is justified by ongoing disease activity, whether measured by the neurofilament, which I think should still be validated, or whether measured by other outcome measures, the use of highly active treatment in older patients is certainly fully justified.
I agree with Antonio on that. You really need to think about risks, and that needs to be the focus, really.
So we've got one last point from Anais, and then we'll draw this to a conclusion. So Anais Thuin has said that Dr. Scalfari explained exactly the core of the issue. What would be the panel response about switching someone later in the disease? So someone who's had multiple sclerosis for a while, who, as far as you can tell, is absolutely stable. Are you still going to switch that person, Shamali, or should we be reticent?
So I'll be stupid to answer that I should switch that patient, to tell you the truth. I think The problem here is it's frequency at which you're monitoring these patients, really. I mean, our annual reviews do not capture what is happening with our patient cohort. As newer measures like PROMs come in, even like walking, little foot insoles, which are what's being developed, we'll start to see the fuller picture of what's happening in MS. Definitely, majority, I'll take this from my clinical experience, really, not evidence-based, but my evidence, that my patients by that age category are quite disabled. So sometimes we're clutching at strings as to offer them something different, and that may be clinical trials, which are at higher risk than our existing treatments because they're unknown. But we like to, as clinicians, offer what is best for our patients. So in answer to that, I don't think every patient is the same. You really need to think about it, and our MDTs allow us to discuss this and maybe argue back and forth about individual patients. But really, if there is an inkling of disease activity, then you should move on it. If there isn't, then you should leave it well alone, because you really would be doing disfavor.
As always, we seem to have agreed on far more than we've disagreed on, despite this being despite this being a debate format. But ladies and gentlemen, I'd just like to run the poll again and see if Antonio or Shamali has swayed your opinion. So Darcy and Hugh, would you mind popping the poll up again? So just to recall the first time round, so about 83% of people agreed with Shamali, and 17% of people agreed with Antonio. Of course, Shamali was preaching to the converted. Antonio was the heretic in the cathedral, and we'll see if we have altered how you think about things. A couple more people to answer. Perfect. So Shamali, the odds always were against against you, I'm afraid. And it's hard, isn't it? It's hard just being the preacher. But I have to hand the win to Antonio. I think your detailed longitudinal understanding of what happens in multiple sclerosis probably just swung things for our audience. But I think, ladies and gentlemen, I think we've agreed on far more than we have disagreed on. I think the main thing that we've agreed on is that actually our thinking about multiple sclerosis and the way in which we are allowed to prescribe drugs doesn't really fit with the lived reality of multiple sclerosis in our clinic, and we're hamstrung by the unknown truths that Shamali pointed out to us about the way in which these drugs have been available to us. Joella and
David, you didn't say the poll results yet.
Oh, sorry. So, Antonio, you won. So you got 40% of people and 60%. So I suppose there's two ways of looking at this. Still, most people believe Shamali rather than you, Antonio, but you have been able to convert a proportion of Shamali's adherents over to your cause. So,
I feel like
both,
you know.
yeah. So I suppose you're both winners in a way. Joella and Noreen, what's our next steps? How are we going to take this fantastic argument forward to make things better for our patients in the UK?
I think we need to develop the research questions and then collect the evidence together. So I think as finger prick neurofilament comes on board, which obviously isn't going to come round today, like we are able to monitor more closely patient. We can tell patients, oh, monitor them weekly, monthly, whatever. But we're not there yet. But it's actually collecting the evidence as a group. So everyone can say, well, in my centre, and Shamali explained her clinical experience, but actually if you're Antonio or David with your patient group, you'll say, oh, my patients are different, because everyone's patients are different. So we need to collect the same stuff as a community to then gain the evidence, so the commissioners and the people that make the rules can then use this. And David's smiling because he sits in some of the meetings where you hear, where they have to look at the evidence, they have to look at published things, and anecdotal evidence does not have weight. sadly.
And I think we've got to listen to our patients and, think about how we could implement changes like this. I think whether or not we switch from lower efficacy to high efficacy, we've probably all still got the same number of patients on treatment, but we have to work out how we can deliver that in our services, because sadly services are not really growing, with the huge number of DMTs that we've got. So it's being smarter with the same amount of capacity, really.
Perfect. Well, thank you so much, Shamali, Antonio, Joella, and Noreen, for a fantastic talk today. I think you've made a very strong point that we need to work much more closely together as a community to get the best outcomes for our patients. That is the perfect segue into this slide here, showing that actually the next year's multiple sclerosis masterclass is now open. So if you've enjoyed what you've heard today and want to work closely with other healthcare professionals in understanding and improving care for multiple sclerosis, these are exceptional ways to do this. So please do register your interest if you wish. Thank you so much for your attention, for your questions, and for your time today. Ladies and gentlemen, I'd like to close the webinar now and hope you enjoy the rest of your day. Thank you very much.
Thank you.
Thank you.
Thank you.